Hope Cook with Dermcast.live. Today I have Dr. Meghan Noe. Dr. Noe is the Assistant Professor of Dermatology at Brigham and Women's Hospital. And you also are the Director of the Immunobullous Disease Clinic, right?
I am.
That's wonderful. How did you get involved in bullous diseases?
So actually, I had a lot of exposure to bullous disease as a resident.
Okay.
When I was a resident, my research mentor, Dr. Janet Fairley, ran a research lab focused on bullous pemphigoid. And so I did research with her actually before, when I was a medical student, and then I went back to the University of Iowa where she worked for my residency. And my continuity clinic, I worked with her. So every week throughout residency, I had exposure to these patients.
Yeah.
And I think it's really interesting to study a rare disease in a subspecialty of medicine. So we saw patients from all over the state of Iowa, and you can see there's really a need for people to understand these rare diseases.
Yeah, because as we were talking before we started recording, when I see bullous, blister rash on my schedule, I'm like, oh no. So what are the first things you tell your PAs or residents to do when they see a patient who has blisters or bulla?
Well, I think your reaction is very common. So the first thing is don't panic.
Yeah.
So while we talked about I'm the director of autoimmune bullous disease clinic, and people may know about severe drug reactions that can present with blisters, in actuality, there are much more common, less serious things that present with blisters in dermatology clinic.
Yeah, so what are some of the most common things that you see? Like, let's say a patient comes in and they have blisters on their feet. What would be some of the first things you would think about?
So this is going to sound silly because friction blisters or just normal blisters are very common.
Yes.
But I do see patients who present with friction blisters that they weren't aware were from trauma.
That's funny, and they got into your clinic, like this probably hard to get into clinic, and they've got friction blisters.
Yes, we also see blisters from edema in the lower legs. That's very common and oftenly misdiagnosed. And then rarely, well, not rarely, we can also see blisters related to cutaneous on the feet.
Yeah. So it depends on location. So what other body parts do you sort of look at and think, I bet I need to rule out this, this, and this?
So anything that presents in a dermatomal distribution, that's a good trigger for shingles, which is fairly common. A key thing for me is mucous membranes.
Yeah.
So if patients are presenting with blisters on more than one body site, I always ask, do they have sores in the mouth, redness, or a gritty sensation in the eyes? That can lead me to believe that there might be eye involvement. And if people have blisters and also mucous membrane involvement, that's a sort of a red flag that they need a full workup. I need to make sure something more serious isn't going on.
Yeah, and you talked about doing not just a regular biopsy, but you also need to do an immunofluorescent biopsy. Can you tell us how to do those? Like, what's the difference, and for people who've never done that?
Yeah, so if I'm concerned that there's a cutaneous autoimmune disease is in my differential, then the best way to arrive at the correct diagnosis is doing 2 biopsies, one for regular H&E and one for, like you mentioned, direct immunofluorescence. I always do punch biopsies.
Yeah.
I think it gives the best information to our pathologists, and I always do 2 because they need to go in separate media.
Yeah.
And you want to make sure that for the H&E, the pathologists have the correct orientation. So splitting a punch biopsy, I think, sort of disadvantages our pathologists.
Okay, and you biopsy regular skin for the direct immuno, right?
Correct. So that's the key, is that your regular H&E specimen should be part blister, part normal skin. So I always go on the edge of the blister. And then further out, next to that, of what looks like normal skin to my eye, I will do the biopsy for direct immunofluorescence.
Okay, and you avoid the legs, right?
Yes, so that's another key pearl that I talked about in my talk today. Biopsies of the leg can have false positives for direct immunofluorescence. They also, in general, don't heal as well, so sometimes create more trouble for patients. So I try not to biopsy below the knee if possible.
Okay, would you ever biopsy a mucous membrane?
So that depends. I think mucous membrane biopsies give us lots of information. I'm very fortunate in that I have great colleagues in the oral medicine department who are great at doing biopsies in the mouth and further back in the mouth. So typically, if the best lesion that I want to sample is the lips, I will do that biopsy.
Okay.
But if it's in the mouth,
Yeah.
I send to oral medicine because I'm lucky to have great colleagues.
yeah.
I do know many of dermatology practices that feel that do biopsy the inside of the mouth, and I think we should feel comfortable
Yeah.
to do it. It's just hard when you don't do it very often.
Yeah, it's hard to get in there.
It is.
So any red flags that we need to be aware of if you have a patient who's very ill looking?
Yeah, so a big trigger is skin pain.
Okay.
So I think when patients present with blisters and skin pain, that can tell you that there's a lot of inflammation in the skin and something very serious going on.
And if they have a fever or...
Correct, and anyone who's systemically ill, fever, chills, anything like that.
If we suspect Stevens-Johnson, what do we need to do? Like, what are the quick 24 to 48 hour steps?
Yeah, so those patients should, if they're not already in an emergency room setting, should be
Yes.
sent to the emergency
Go.
room. But before that, doing a biopsy. And in this case, a lot of times I will also do a biopsy for direct immunofluorescence because Stevens-Johnson syndrome does have some mimickers. So getting that skin biopsy so it can be processed as quickly as possible.
Okay.
Telling them to stop all medications
Yeah.
if that's possible. And then they should be closely monitored in an emergency room or even inpatient observation setting because Stevens-Johnson syndrome tends to progress very rapidly.
Do not send them home and say, we'll call you in a week with your results.
Correct.
Anything else that you see commonly, like common mistakes that people make when they're seeing patients with blistering disorders?
So the trickiest part about blistering disorders, I think, is that the differential diagnosis is so broad. So trauma and injury can cause blisters, infection can cause blisters.
Like staph.
Exactly. Drug reactions like we talked about, and then the rare blistering diseases. So I think the key is to go in with a broad differential and sort of really look at the lesions, look at how they're distributed, see what sort of clues you can get just from the physical exam.
Yeah, and you talked a lot about whether the blister was flaccid or tense. Can you tell us, like, how do you differentiate the two?
Yeah, so a tense blister will present to your clinic as a blister. You can put pressure on it and it won't pop.
Yeah.
Whereas a flaccid blister is much more fragile. It's rare to see them in clinic. So instead what you'll see is an erosion or like a little bit of crusting. And the reason why the difference is important is because it tells us where the problem is in the skin. So when the insult to the skin is higher up, then that will produce a flaccid, more fragile blister. If it occurs at the junction of the dermis and the epidermis, that tends to present with more of a tense blister. And just by knowing that, you can already sort of sort out your differential diagnosis and exclude or include some things.
Gotcha. And then you also mentioned that you send them home with high potency topical steroids, depending on what it is, sometimes medium potency. Do you have them put it on there like 4 or 5 times a day? Do you?
Yeah, so for anything inflammatory, so blisters from contact dermatitis, the autoimmune diseases, then I do treat with a lot of high potency steroids. I think practically patients can really only apply topicals twice a day. Honestly, that's asking a lot. I don't know if I could apply my
10 times a
topicals
day.
twice a day. So a lot of times I'll say twice a day around the blister. To help with that inflammation. Sometimes if patients are doing wound care where they're wrapping, then once a day is enough because you know that medicine will stay almost under occlusion, like with their wraps or their dressing.
Yeah, that makes sense. When you have elderly patients with blisters, you mentioned bullous pemphigoid. What should we be looking for?
Yeah, so bullous pemphigoid is a key. Don't miss this.
Yeah.
Because while we read about or we hear that it presents with tense blisters, most patients present with some sort of prodromal phase. So I've seen patients who are just itchy.
Yeah.
But if you really think about it, they're more itchy than the average person.
Okay.
I know we all see tons of itchy patients, but seems like a more intense itch.
Okay.
And then there are some people who present with a more eczematous eruption. So it looks just like average, run-of-the-mill eczema. And if those patients, either lots of itching or pruritus and eczema, aren't responding to your several treatments after a month or two, I think you should really have a low threshold to do a biopsy to try to rule out bullous pemphigoid, because it's easy to miss in these patients.
Yeah, it is. I mean, we do see a lot of itchy elderly patients. So would you go ahead and do an H&E and a direct immuno?
I do. I think I've seen cases where the H&E looks more like classic eczema. So it sort of exists on a spectrum with bullous pemphigoid, where when you get to bullous pemphigoid, you have much more eosinophils, greater spongiosis, and that's what causes the blister.
Yeah.
And so I've seen patients where the H&E looks more like a classic eczema with sort of minimal of those features, but the direct immunofluorescence is positive, and that's the key to the diagnosis.
Okay. And you also said something about you don't just treat them and then the blisters go away and then you withdraw the treatment. Can you say more about that?
Yeah, so I think one of the misconceptions about these cutaneous autoimmune diseases is that they are chronic diseases. And so because of that, they require ongoing treatment.
Yeah.
And so for most patients, once I get them clear, I reduce the medication if possible, so they're on the lowest amount of medication to keep their disease under control. But many patients, if you stop their medication completely, then they'll have a big flare.
Yeah.
And so really try to avoid that.
I haven't tried, you mentioned methotrexate, 10 milligrams a week. I haven't tried that, but.
That's a good place to start with a lot of my bullous pemphigoid patients. The 10 milligrams is low dose. I don't have a lot of issues with side effects. Even in patients with underlying comorbidities, a lot of times they will tolerate it. Some patients do need more higher doses, like we use for other things in dermatology. But for a lot of people, 10 milligrams of methotrexate once a week is a good place to start.
Yeah. Oh, those are great tips. Are there any other things that you wish we all knew?
Oh, that's a great question. I think, especially when you're worried about an autoimmune blistering disease, I think referring the patients out or asking other colleagues, I think the things are so rare, and so we don't see them very often. So have a low threshold to think about them and ask the tests. But also, even I will show pictures, clinical pictures to some of my friends or bring in other doctors. What do you think? What I could be missing? I think that's sort of a good rule of thumb for anything that's rare in dermatology.
No, that's perfect. Thank you, Dr. Noe.
Yeah, thanks so much for having me.
Yeah. Hope Cook signing off with Dermcast TV.